Hello, I'm Alan Braverman, Professor of Cardiovascular Disease at Washington University School of Medicine. Today, I'm going to present aortic dissection, emergency room presentation, and next steps. This is part of the Aortic Disease Awareness Week lecture series on aortic dissection. Thank you for attending. Aortic dissection is a highly lethal condition requiring urgent treatment, and importantly, may mimic many other conditions much more common in the emergency room. It's estimated about 10,000 acute cases of aortic dissection occur in the US each year. 15 to 40% of people ultimately proven to have an acute dissection are not diagnosed while undergoing their evaluation in the emergency room. Many are diagnosed on imaging studies which are performed for a different reason. And unfortunately, many are diagnosed at post-mortem. So one of the most important factors leading to a correct diagnosis of this condition is a high clinical suspicion that aortic dissection may be the cause of the person's presentation. So how do we think about that? How do you approach people in the emergency room when so many are there? Consider aortic dissection in patients who present to the emergency room with chest pain, back pain, abdominal pain, syncope, or have a malperfusion syndrome, or present with shock or hypotension. And if you think about, does the individual that I see have a high-risk condition? Do they have a high-risk pain feature that should make one suspicious of aortic dissection? Or could they have a high-risk feature on examination, heightening the suspicion for aortic dissection? High-risk conditions include those at risk for aortic aneurysm dissection, like Marfan Syndrome, Loeys-Dietz syndrome, or vascular Ehlers-Danlos syndrome, or a familial aortic syndrome, so they have a family history. Do they have bicuspid valve disease, or a known thoracic aneurysm that's being followed? Or have they had aortic manipulation? All conditions at risk for aortic dissection. Does the individual have a high-risk pain feature? That would be chest pain, back pain, or abdominal pain that's abrupt in onset and severe in its intensity, often described, or more commonly described, as sharp or stabbing, less commonly ripping and tearing, but adjectives of importance in making you consider this as a diagnosis. And does the individual have a high-risk examination feature, such as evidence for a perfusion deficit? So that would be an abnormal pulse in one extremity, or a difference in blood pressure between the arms, or the arm and the leg, or a focal neurological deficit, like chest pain and stroke, or chest pain and aortic regurgitation murmur, or hypotension and shock. So think about these conditions when you have a patient with unexplained chest, back, or abdominal pain, or these other features. And it'll enhance the yield of diagnosis of aortic dissection. So take a very careful history. Aortic dissection typically begins with the abrupt onset of severe pain, and that's different than the crescendo or increasing discomfort of coronary ischemia. Remember, when the arch vessels are involved in dissection, often severe neck or head pain can predominate and can mimic other headache syndromes. The pain is severe in about 90% of individuals, and adjectives such as sharp and severe are the most commonly used. When ripping and tearing are used, they heighten our suspicion, but these are less commonly used. It's maximum intensity at its onset, or in other words, abrupt in onset, and people typically remember exactly what happened and when. I was in the shower and all of a sudden got struck in the back by a baseball bat or stabbed with a knife. So cataclysmic type symptoms should make you think of this condition. It's migratory or traveling from chest to back or back to chest or chest to abdomen in about 17% of people as the dissection propagates. And again, differing than many other chest pain syndromes, those with dissection are often restless, have a sense of doom, and are very uncomfortable, asking something is very wrong or am I going to die? So these are very worrisome appearances of individuals that should make one think of this condition. This is a study looking at 83 people from emergency room with acute aortic dissection. And the initial physician correctly suspected dissection in 65% of cases. Only 42% of people were asked all the descriptors of their pain, like what was its quality, where was it, and what was its onset like. And in 19 people, only one or less of these descriptors was recorded in the record. And interestingly, when all three questions were asked and answered, dissection was correctly suspected in the vast majority, whereas when less information was obtained about the type of pain, the dissection was less often suspected. So take a very careful history and think about this when approaching the patient in the emergency room. People with aortic dissection often look acutely ill. Hypertension is present in about half the individuals in the emergency room with dissection, but not in all. And low blood pressure or hypotension occurs in 20%, usually due to acute complications like pericardial tamponade or rupture or exsanguination or acute heart failure due to acute severe valvular regurgitation from the dissection process. Aortic regurgitation is present in about 40% of type A dissections, and pulse deficits depend upon which dissection, more common in type A than type B. But again, the majority of individuals will not have aortic regurgitation or pulse deficits. So when present, they should heighten your suspicion, but when absent, should not exclude evaluation for dissection. And almost 10% of people with dissection present with fainting or syncope. Again, classifying dissection because type A dissection, in which the ascending aorta is involved, requires emergency surgery. Type B dissection, or type 3, is distal to the left subclavian, and these descending dissections are typically managed medically unless a complication occurs. This slide highlights the importance of early recognition and treatment of aortic dissection, and is based on the IRAD classification system for characterizing survival. If you look at the very early hours after a dissection, and this is called the hyperacute phase, from 0 or from onset to the first day, you can see with medical therapy of a type A dissection, almost 20% of individuals have not survived. And that leads to this almost 1% per hour risk of death in the first day of a type A dissection. So it highlights how important it is to recognize this and have treatment early on. Type B dissections have a less mortal outcome when treated medically early unless a complication occurs. The risk of death with dissection, type A or type B, is highly increased by complications such as rupture or malperfusion syndromes. And again, in type B or descending dissections, lower mortality rate when uncomplicated, but about a quarter of patients do develop complications or become unstable. And those who do have a much higher morbidity and mortality rate early on. The complications of dissection which may arise in the emergency room or thereafter include frank rupture of the aorta, as demonstrated here with hemorrhage into the peritoneum, bleeding around the heart, leading to cardiac tamponade, or bleeding into other spaces like the mediastinum or pleura, which can be fatal. Acute aortic valve regurgitation occurs in type A dissection because of the intimal flap, and this leads to aortic regurgitation, which can be manifest as heart failure or a loud diastolic murmur of aortic regurgitation where previously was not present. This highlights the importance of looking for this physical feature on examination of acute dissection or people suspected of dissection. Malperfusion occurs in about a quarter of patients with dissection. The most common is known as dynamic malperfusion. So in this cartoon, here's the dissection with the tear in the aortic wall leading to the intimal flap, the true lumen, and the false lumen or the false channel. Increased pressure in the false channel leads to collapse of the true lumen, which can interfere with blood flow in a branch vessel and lead to malperfusion in any vascular bed. Static malperfusion has a similar mechanism, but instead of being dynamic, there's occlusive flow or occlusion of this branch vessel, usually due to thrombosis or the dissection flap extending into the branch vessel, leading to ischemia or infarction of that vascular territory. So the clinical features of aortic dissection can be dominated by malperfusion, leading to symptoms like stroke or coronary ischemia or mesenteric ischemia or limb ischemia, depending upon which blood vessel is involved. And that highlights how difficult it can be to suspect or diagnose dissection, because the features can involve any of the organ systems as outlined on this chart, whether it be the heart, the lungs, the kidneys, the brain, the spinal cord, GI tract, or others, depending upon which blood vessel is involved in malperfusion or whether there's rupture or involvement of these organ systems. When facing a patient with suspected dissection, urgent evaluation is required, first to exclude other possibilities that are more common and to do diagnostic tests to identify the aortic dissection, which is typically CT scan as the #1 test done in the emergency room. CT scan with contrast, TEE, and MRI have the highest accuracy for diagnosing aortic dissection, between 95 and 100%, with contrast CT scan being the first choice in the emergency room due to its widespread availability and speed of access. The chest X-ray can have features like this one with a widened mediastinum or a prominent aortic knob, which can make you suspicious for dissection, but 20% of individuals with an aortic dissection do not demonstrate those features and have a normal chest X-ray or minor nonspecific findings. So remember, a normal chest X-ray cannot exclude an aortic dissection. This individual with the prominent aortic knob had a type B dissection, and you can see the aortic shadow being abnormal here in this radiograph. Biomarkers can be very helpful in suspected aortic dissection, and D-dimer is the one that's most readily available and has the most data supporting its use. So D-dimer is the degradation product of fibrin and is elevated during activation of the clotting system. Acute aortic dissection leads to marked activation of the clotting cascade, and some of the highest levels of D-dimer that one recognizes are present in acute aortic dissection, especially early on and in the first several hours after dissection. Importantly, D-dimer has been reported normal in aortic intramural hematoma, in which there's no intimal flap, or penetrating ulcer. So if you have a high suspicion of an acute aortic syndrome, the D-dimer should not be used to rule out this condition. Thinking about the aortic dissection risk score, we talked earlier about recognizing the condition. Does a person have a high-risk condition like Marfan or others? Do they have a high-risk pain feature like severe chest pain, back pain, or abdominal pain abrupt in onset? Or do they have a high-risk exam feature like pulse deficits or aortic regurgitation or shock? There are three possibilities here. And aortic dissection is more likely the more of these possibilities that are present. The D-dimer can be complementary to the clinical examination. In the person in the emergency room who has acute chest or abdominal symptoms and one has suspicion of aortic dissection that's high, direct imaging is recommended as the next step to evaluate for dissection. But in individuals at much lower risk with a dissection risk score of 1 or less, a D-dimer can be helpful. If the D-dimer is elevated, imaging is recommended. If the D-dimer is normal and the risk of aortic dissection is very low, studies using this algorithm have demonstrated that in low suspicion cases, a normal D-dimer level only missed 0.3%, or 1 in 300 cases of aortic dissection. So remember this in the emergency room, and when you're thinking about dissection in low-risk individuals where it's still in your differential and you haven't gone on to do imaging. If the D-dimer is elevated, that might heighten your suspicion and allow you to go forward with this testing. And a normal D-dimer in a low-risk individual is typically not an aortic dissection. CT scan, again, most commonly used in aortic dissection in the emergency room, highly sensitive and specific, but you must use contrast. Here's an example showing the intimal flap with the small true lumen and the larger false channel. The true lumen typically has more intense contrast opacification and is usually smaller and compressed as compared to the expanded false channel of aortic dissection. This is a type B dissection without contrast, and one cannot recognize the dissection or the intimal flap. With contrast, you can see the same slice of the same individual showing the dissection flap. So very important to give IV contrast to make the diagnosis of aortic dissection. Transthoracic echocardiogram can be done in the emergency room and see features that, like this intimal flap that can be diagnostic of aortic dissection. But it's not as sensitive as other modalities, about 75% sensitive for type A, lower in type B. So you can't exclude dissection with transthoracic echocardiogram, but you can diagnose it. But sometimes features like a dilated aorta, aortic regurgitation, or pericardial effusion may make you think this person could have dissection and heighten your awareness, allowing rapid or expedited imaging such as CT scan for the emergency room. Transesophageal echocardiogram, again, highly sensitive and specific for dissection, over 95%. MRI, very sensitive and specific, but it takes longer, less monitoring of the individual, not as readily available. It's typically done for follow-up as opposed to acute studies. Finally, aortic intramural hematoma in the emergency room has a crescentic shadow or density around the aorta of the blood in the wall of the aorta. And our non-contrast study shows this crescentic wall thickening with enhancement. And penetrating ulcers is the other form of acute aortic syndrome that can be recognized by imaging, often presenting with the same symptoms of acute aortic dissection. Once the dissection is identified in the emergency room, prompt blood pressure control is critical. The goal is to lower blood pressure to the lowest level that's associated with adequate tissue perfusion, typically less than 120 millimeters of mercury. Beta blocker-based treatment is paramount because it lessens the rate and risk of propagation of dissection and risk of rupture. So typically IV beta blockers such as esmolol or labetalol are given, and they allow rapid titration. And many individuals require multiple antihypertensive agents. Emergency cardiothoracic surgery is necessary for type A dissection and emergency vascular surgery for type B dissection, especially when complicated. All individuals not undergoing urgent surgery are admitted to an ICU, and it's recommended they be in a tertiary care center with cardiothoracic surgery, vascular surgery, and cardiology consultation immediately available to deal with complications which can occur, with close observation of vital signs in laboratories and neurological status. Type A dissections, again, emergency surgery is associated with a much improved survival than is medical management. With type B dissections, patients that are complicated have a much worse prognosis. So those with rupture, impending rupture, malperfusion, refractory pain, aneurysm, or uncontrolled hypertension, and have favorable anatomy, typically undergo endovascular repair. Uncomplicated dissections who have high-risk features for progression, such as large entry tears or aneurysms, large false lumen diameters or saccular aneurysms, often undergo early TEVAR, but in the absence of high-risk features, medical management with optimal blood pressure control is recommended. Endovascular therapy has lessened the morbidity and mortality of complications of type B dissections. To summarize, in the emergency room, consider aortic dissection in individuals presenting with chest, back, or abdominal pain, syncope, or features of malperfusion, and ask, does a person under investigation have a high-risk condition which can associate with risk of dissection, like Marfan, familial aneurysm disease, bicuspid valve disease, a known aneurysm, or have they had aortic manipulation? Do they have high-risk pain characteristics, such as abrupt onset of a severe or sharp pain? Or do they have high-risk physical exam features, such as aortic regurgitation, pulse deficits, differential blood pressure, syncope, or hypotension. These are all features which should highlight your concern for aortic dissection. And then pursue imaging, typically a gated contrast CT scan to evaluate aortic dissection. In very low risk individuals who don't have an explanation for symptoms, you can consider D-dimer testing, which is useful when normal, but not 100% accurate. And when a dissection is diagnosed, initiate beta blocker therapy, aiming for adequate blood pressure control. Consultation with CT surgery is necessary for urgent repair in type A dissection, and other specialists, include vascular surgery, CT surgery, and cardiology, are involved for dissection management, especially type B. In the long-term management after aortic dissection, here's an easy tip. Besides making the diagnosis and achieving blood pressure, changing lifestyle, and exercising moderately, remember, these conditions can run in families, so evaluate relatives for a familial disorder that can put them at risk for dissection, image the aorta over time, and do preventative aortic repair as appropriate. Thank you very much for your attention, and protect the tube of life.